Welcome to the Deep Dive. We're here to cut through the noise and get straight to the insights that matter. Today, we're tackling a really fundamental topic, maternal mortality and infant health. And just to kick us off, here's a truly stark fact for you. Globally, for every woman who tragically dies during childbirth, about 20 others suffer a major injury, infection, or disease. That's something like 10 million women every single year. It's just a staggering human cost, isn't it? So our focus today is really to unravel this complex reality, especially looking at developing nations like India. And this isn't just about the numbers, it's about this whole intricate web of lives, health systems, and cultural practices that shape these outcomes.
Exactly. And our mission today is really to sift through the detailed sources you've shared with us. We want to reveal the most critical insights and explore how all these factors, the medical, the social, the governmental, how they all connect. We want to help you understand not just what's happening, but, why it matters on a much bigger scale for global health, for society's well-being.
And crucially, we won't just focus on the challenges, which are, let's face it, significant. We'll also unpack the remarkable progress that's being made and some really innovative solutions being used to tackle this global health crisis. Okay, so let's unpack this a bit. Before we really dive into the why and how, we need to be clear on what we're talking about. What exactly is maternal death, and how do we even measure something so critical?
Right, that's foundational. So officially, maternal death is defined as the death of a woman while she's pregnant, or within 42 days of the end of the pregnancy. And it has to be from a cause related to, or made worse by, the pregnancy or how it was managed. Importantly, it's not from accidental or incidental causes. We generally break it down into two types. Direct obstetric deaths, these come straight from pregnancy complications, like severe bleeding after birth, or hypertensive disorders like eclampsia. And then there are indirect obstetric deaths. These are from pre-existing conditions, maybe heart disease, kidney issues that just get worse because of the physiological stress of pregnancy. Oh, and there's also a category called late maternal death, which happens after that 42-day mark, but within a year from obstetric causes.
Okay, that's clear. And to quantify this, to really get a handle on the scale of the risk, we use the maternal mortality ratio, the MMR. How does that help us see the bigger picture?
The MMR is incredibly insightful. It's basically the number of maternal deaths during a given time period for every 100,000 live births in that same period. So it measures the risk of a woman dying in relation to the number of babies born alive. It gives us a standard way to compare outcomes, across regions over time. It's actually a pretty stark indicator of how well a health system is functioning.
And when we look at those MMR numbers globally, the difference between regions is quite dramatic, isn't it?
It really is. What's striking is the sheer difference in risk. So globally in 2017, we're an estimated 295,000 maternal deaths. But that global average, 211 deaths per 100,000 live birth, it kind of masks this profound inequality. In the world's least developed countries, that ratio jumps to an estimated 415.
Yeah.
It's more than 40 times higher than in places like Europe. This isn't just a statistic. It reflects massive differences in access to basic life-saving care. But, it's not all bad news. South Asia, for example, actually achieved a really impressive 59% reduction in MMR between 2000 and 2017, dropped from 384 down to 157. So it shows that focused efforts can make a huge difference.
Right, and bringing that closer to home, looking at India specifically, India's MMR has dropped significantly too, from 167 per lakh, that's 100,000 live births back in 2011-13, down to 97 in 2018-2020. That's real progress, moving India closer to those sustainable development goals. But it still means an estimated 44,000 mothers dying each year. India is still considered among countries with a high maternal mortality ratio. What does that tell us?
Yeah, it tells us that while the progress is definitely there and it's encouraging, there's still a really significant journey ahead. The MMR, when you get down to it, is a powerful reflection of a nation's overall health system effectiveness. And the core insight here, I think, is that the vast majority of these maternal illnesses and these tragic deaths, they're actually preventable. They often stem from a lack of timely access to basic good quality care rather than, unavoidable medical conditions.
So what does this all mean then? These numbers, even showing progress, they still point to really deep-rooted issues. Our sources really emphasize that maternal deaths are multifactorial. It's a complex mix, medical, social, economic, cultural challenges. It's not just one single thing. Let's dig into those causes now, maybe starting with the immediate medical ones and what they reveal about the bigger picture.
Okay, the immediate medical causes are, often the direct threats. But the fact that they persist really highlights these underlying system gaps. Hemorrhage or severe bleeding is the single biggest one. accounts for about a quarter of all maternal deaths, usually right after childbirth. And this is particularly devastating because, honestly, with timely help, it's highly treatable. Then you have sepsis, severe infection. That's responsible for maybe 11–15% of deaths, often linked to poor hygiene during delivery. Eclampsia and other hypertensive disorders, they contribute another 12–13%. And tragically, unsafe abortion, often done by untrained people outside proper health services, that accounts for a significant chunk, maybe 8–13% of deaths. Obstructed labor, where the baby just can't pass through the birth canal, causes about 5–8%. And we really can't forget anemia. It's kind of a silent, indirect contributor. It affects about half of all pregnant women. And it basically makes all these other causes much more deadly, reduces a woman's ability to cope. Then there are the indirect causes, too, those pre-existing diseases that pregnancy makes worse, like heart disease, TB, malaria. Malaria alone causes about 10,000 maternal deaths a year in endemic countries, and HIV/AIDS. What's really striking is how many of these, like the bleeding or the infections, are often preventable with just basic medical care and getting it on time. It suggests the challenge is often more about delivery of care than discovering new cures.
That's a really powerful point, that so many are preventable. But moving beyond the purely clinical, what's fascinating is how deeply these social and cultural factors come into play, especially in places like India. These aren't just background noise, they seem to directly shape health outcomes.
Oh, absolutely. We see several really adverse sociocultural factors creating this complex web of risk. Women's age is a big one. Pregnancies before 20 and after 35 carry much higher risks. And teenage pregnancies are often particularly at risk because of, well, physical immaturity, but also lack of social support. Birth spacing is also critical. Short gaps, like less than 3 years between births, and high parity, meaning too many pregnancies, especially after the third ones, significantly increase complications for both mother and child. Then there's the pervasive issue of low socioeconomic status and illiteracy. You tend to find that poorer or less educated women often marry earlier, get pregnant more frequently, and often don't use antenatal care or deliver in facilities as much. Whereas conversely, more educated women tend to marry later, delay starting a family, and are generally better at accessing health services. The early age of marriage in India is a huge factor here. Something like 60% of girls aged 15–19 are already married. That shortens their reproductive window and increases lifetime childbearing risks.
And then we get into traditional customs. Our sources highlight some really impactful, quite vivid examples of how these customs, often well-intentioned, can inadvertently put mothers and babies in serious danger.
Yeah, absolutely. One really potent example is son preference. This often leads couples to keep having children until they have a boy, resulting in higher parity, more pregnancies, and therefore increased risk for the mother. Childbirth practices themselves are another major area of concern. Many women in rural areas prefer home deliveries with untrained traditional birth attendants, often called dayas, and the conditions can be highly unhygienic. The sources describe some really shocking practices, delivering on straw mats, using the husband's unsterilized razor to cut the umbilical cord, even applying things like cow dung to the cord stump. These practices just drastically increase the risk of infections, including life-threatening things like neonatal tetanus. Then you have harmful food habits and taboos, like discarding colostrum, that first nutrient-rich milk, because some believe it's witch's milk, or prohibiting really nutritious foods like eggs, meat, or fish during pregnancy, which just makes anemia worse. A significant barrier is also just a distrust of modern medicine. Many people still prefer traditional healers over doctors and hospitals. All these different factors feed into what we call the 3 delays. That's delays in deciding to seek care in the first place, delays in actually reaching a suitable health facility, and then crucially, delays in receiving quality care once they get there. These delays can turn preventable problems into fatal ones.
Wow, okay, this raises a really important question then. With such a complex web of causes, medical, social, cultural, what are the solutions? Our sources detail what looks like an impressive multi-pronged approach. It seems to wisely combine clinical knowledge with social intervention, trying to tackle these layers simultaneously.
Yes, the measures to prevent maternal mortality are indeed comprehensive. They aim to sort of intercept risk at multiple points along the way. Fundamentally, it starts with early registration of pregnancy and making sure women get adequate antenatal care, ANC. That means at least 4 ANC visits. These visits are crucial for proper assessment, identifying risks early, and giving key interventions like iron folic acid tablets for anemia, screening for infections, and tetanus shots. Equally vital are clean delivery practices, emphasizing what's often called the 5 cleans: clean hands, clean surface, clean cord tie, clean cord stump, and a clean blade or razor. Each one of those cleans sounds so simple, but they are profoundly impactful. They drastically cut the risk of life-threatening infections for both mother and baby, even if the delivery happens at home. Promoting skilled birth attendants, SBA, having a trained person present, and encouraging institutional deliveries is key, especially for any woman identified as high risk. But, if complications do arise, then access to emergency obstetric care, EMOC, is absolutely non-negotiable. This means having essential and comprehensive services ready at designated first referral units, FRUS. Things like blood transfusion capability, obstetric surgeons, anesthetists. And care doesn't stop at birth. Postnatal care, PNC, is essential for up to 42 days afterwards, focusing on the mother's health, preventing complications, and providing vital family planning advice. Which brings us to family planning promotion. Helping couples control the number of children and ensure proper birth spacing is really critical. This includes access to contraceptives and safe abortion services where needed. And ultimately, underlying all of this, there's the need for broader socioeconomic development and women's empowerment, tackling poverty, illiteracy, early marriage as long-term prevention.
It's really helpful to hear about what should be done, but let's talk about what is being done. What's truly impressive here is the sheer scale and the strategic thinking behind the government of India's efforts to tackle these deep-seated issues. How are they approaching this from a policy angle?
Yeah, the government of India has implemented a really robust and importantly evolving set of programs. They're designed to hit both the medical and the social determinants. Take the Reproductive and Child Health or CH program, especially phase 2 from 2005. That significantly scaled up rural healthcare access and really pushed for institutional deliveries. Then a major innovation was the Janani Suraksha Yojana, JSY, launched in 2005. It's a centrally sponsored scheme. It actually provides cash assistance directly to mothers as an incentive for them to deliver in a health facility. And it's coupled with vital support from the SHAs, those accredited social health activists, the community health workers. Building on that, the Janani Shishu Suraksha Karikam, JSSK, from 2011 goes even further. It offers completely free delivery, including C-sections if needed, in public health institutions. And that covers everything: drugs, tests, blood, food, even transport. It removes the financial barriers. More recently, the Pradhan Mantri Surakshit Matritva Abhiyan, PMSMA, started in 2016. This provides fixed-day, free, quality antenatal checkups, and it even brings in private sector doctors volunteering that time.
And the Lucretia program from 2017 specifically aims to improve the quality of care in labor rooms and maternity operating theaters, so it's directly tackling that quality aspect of the 3 delays. There's also a landmark midwifery initiative creating a new cadre of nurse practitioners focused on woman-centered care. And the RMNCH plus A strategy from 2013, that was a real paradigm shift. It integrates care across a continuum from adolescence through pregnancy, childbirth, postnatal, and newborn care, and strengthens the links between different levels of care. So you can see these programs together show a real shift towards incentivizing institutional care, empowering community workers, and making critical services free, tackling both money and access issues head-on.
That's an incredible range of initiatives. It really shows a comprehensive national strategy. This brings us to a crucial strategy used in modern maternal care: the risk approach. It sounds like it's about being proactive, not just reactive. How does this approach help healthcare providers focus their efforts on those who need the most attention?
Exactly. The risk approach is essentially a smart management tool. It's designed to identify pregnant women who are at high risk of complications as early as possible. The whole purpose is to arrange for specialized, skilled care for these individuals, making the best use of what are often limited resources, like specialist time or ICU beds. But it's also about ensuring that all mothers still receive the appropriate level of care they need. It's about being proactive to try and prevent complications before they become dangerous.
Okay, so what exactly flags a pregnancy as high risk in this system? What are the key things doctors and health workers are trained to look for?
Right, so they look for specific factors that we know significantly increase the chance of complications. These include extremes of age. So teenage pregnancy under 20, or what we call advanced maternal age. That usually means a first pregnancy over 30 or any pregnancy over 35. Parity is another key indicator. That's the number of previous pregnancies. A first pregnancy, called nulliparous, has certain risks. But a grand multipara, someone with 4 or more previous pregnancies, especially if the births were close together, that dramatically increases risk. A woman's previous obstetric history is really important. If she's had complications before, like a stillbirth, a C-section, or a very difficult labor, that flags her as high risk now. Then, during the current pregnancy, certain issues are immediate red flags. Things like bleeding after 28 weeks, the baby being in an abnormal position, malpresentation, or developing conditions like eclampsia or preeclampsia. Underlying maternal health conditions are critical too. Things like severe anemia, heart disease, diabetes, HIV, and even lifestyle factors can play a role: smoking, alcohol, doing excessively heavy physical work, or being from a very low socioeconomic background can add to the risk profile. Identifying these early allows for targeted monitoring and care.
Got it. To make all of this really concrete, let's look at a specific scenario from our sources. Imagine a 21-year-old woman, it's her first pregnancy, and she delivers a baby girl who weighs just 1.5 kilograms, and this happens 4 weeks before her due date. What does this situation immediately tell us about the risks involved and the kind of highly specialized care that's needed?
Okay, yeah, this is a scenario that's unfortunately quite common, and it's fraught with significant challenges, mainly for the newborn. It illustrates multiple high-risk factors coming together. So this baby is both preterm, born around 36 weeks or maybe even earlier, meaning her organs just haven't had time to fully mature, and she's also very low birth weight, the LBW. At 1.5 kilograms, she's well below the standard 2.5 kilogram threshold for low birth weight, making her incredibly vulnerable. Now, while being a first-time mother, a prima gravida can sometimes add a layer of complexity, the really critical factors here are the prematurity and that very low weight. They signal a high-risk situation needing immediate, very specialized care.
So what kind of specific problems would a tiny baby like this typically face, given she's premature and so small?
Well, the consequences for a baby like this are really a cascade of difficulties. There's a high risk of complications across almost every system. Because her organs are immature, she'd likely struggle with temperature instability, to just find it really hard to stay warm on her own. She'd probably face severe respiratory problems because her lungs aren't fully developed, maybe lacking surfactant, which keeps the air sacs open. Cardiovascular issues like unstable blood pressure are common. She'd also be susceptible to blood and metabolic issues like anemia or jaundice. Gastrointestinal difficulties are a major concern too, problems feeding, digesting because her gut is immature. And beyond those immediate things, there are serious risks of neurologic complications, like bleeding in the brain or problems with vision development later on. And crucially, a very high susceptibility to infections. Her immune system is underdeveloped. Longer term, sadly, there's an increased chance of developmental delays, maybe issues with growth, stunting, and sometimes even lifelong disability. The core issue is that prematurity means every single system is fragile.
That sounds like an incredibly tough start in life. What kind of care would she need, both right at birth and then moving forward?
Yeah, the care has to be really specialized and meticulous. It's all about compensating for her underdeveloped systems. Right at birth, if she isn't breathing properly, prompt neonatal resuscitation is the first step, absolutely crucial. Then, immediate warmth is paramount. Dry her quickly, wrapping her well, and initiating kangaroo mother care, KMC, as soon as possible. That's skin-to-skin contact with the mother. It's incredibly effective for warmth, bonding, and regulating breathing and heart rate. Hygienic care is vital to prevent infection, and the vitamin K injection is standard to prevent bleeding issues. Now, for a baby weighing only 1.5 kilograms, she would absolutely need care in a specialized unit, a neonatal intensive care unit, an ICU, or perhaps slightly less intensive settings like special newborn care units, the SNCUs found in India. Feeding is critical but tricky. Expressed breast milk is the best food, but she'd likely need it given through a tiny tube into her stomach called a nasogastric tube, starting with small, frequent amounts, maybe 75 milliliters per kilogram per day, and slowly increasing. Sometimes caloric supplements, like adding a bit of coconut oil to the milk, might be needed, along with essential vitamins like A and D, iron, and calcium.
Okay, and what about after she gets stable enough to leave the hospital? What happens then?
Well, KMC shouldn't stop when she goes home. It should continue as much as possible. Plus, she'd need frequent home visits from community health workers, like the ASHAs in India. They would monitor her weight gain very closely and provide extensive counseling and support for the parents, teaching them how to maintain warmth, ensure exclusive breastfeeding if possible, and crucially, how to recognize danger signs that mean she needs to come back to the hospital immediately. And very importantly, babies like this need long-term follow-up, usually for at least 2 years. This is to screen for any birth defects that might not have been obvious at first, and to check for developmental delays so that early intervention can start if needed. And for the mother herself, her own comprehensive postnatal care is vital for her recovery. She needs counseling on the factors that might have contributed to the preterm birth or low birth weight, things like her nutrition, anemia, any infections she might have had. And perhaps most importantly, she needs really good family planning advice. Proper birth spacing, ideally at least 3 years, is central to allow her body to fully recover before considering another pregnancy. Methods like IUDs, which can be put in soon after birth, or progesterone-only pills that don't interfere with breastfeeding are often good options.
We've covered a really tremendous amount of ground today, moving all the way from those big global statistics right down to the intimate details of a specific, challenging birth. We've talked about national policies and also those deeply personal choices that are often influenced by tradition.
Yeah, and what's really fascinating here is how all these seemingly separate elements actually connect, isn't it? Maternal and child health isn't just about individual outcomes. It really is a powerful indicator of a society's overall health and well-being. That's like a mirror reflecting its investment in the future. The health of mothers and babies truly is the foundation for a thriving community.
Absolutely. And the journey towards zero preventable maternal and infant deaths, it's clearly a long one. But as we've seen today, incredible strides are being made. There's dedicated effort happening at every level, proving that these tragedies don't have to be inevitable.
So, thinking about all this, what does it mean for you, our listener? Consider how understanding these complex challenges from the specific medical interventions and government programs right through to those subtle shifts in cultural norms, how that understanding empowers us. It helps us recognize the profound impact global health initiatives can have right down to the community, even family level. And here's something to think about. What role do you think continued innovation, maybe in technology, maybe in strengthening local community involvement, what role does that play in speeding up the reduction of these preventable tragedies even further?